just guesstimate. So if I have a guy who can't move his legs but he can move his arms, then I'll just start marching up. Go, can you feel this? Can you feel this? No, 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 no. Yes, yes, yes. And then I just mark a line with my pen. Okay, and that's where I change over. That's got loss of function below that. I have function above it. Where does that correlate? T6. So my estimate is I got a mid-thoracic spine injury. Okay, make sense? What do we say? C3, 4, and 5. Phrenic nerve keeps the diaphragm alive. Respiratory paralysis is what happens. C5 through T1 is my brachial plexus. It's going to give me axillary, radial, median, musculocutaneous, and ulnar function. So all these abilities to extend, flex, all those hand grip. And truthfully, that exam is really easy, right? I just say, squeeze my fingers tight, pull in towards you, push towards me, fan your fingers all out real wide, don't let me squeeze them together, and then bring your wrist back like you're flexing or like you're riding a motorcycle, right? And that's there, everything's intact. Okay, it's that easy. And then I can say at least median, ulnar, radial, and actually I can comment on musculocutaneous too. So I can say brachial plexus, essentially the motor function of brachial plexus is intact. And if I want to do sensory, then I say, does it feel equal on both sides? Equal on both sides, equal on both sides, equal on both sides. That's hit sensory, okay? So I can do a detailed upper motor neuron exam and upper, essentially I just call it sensory motor of the median, ulnar, radial, musculoskeletal is intact, okay? Which gives me much more detail. Now, if I've got a guy who can grip and pull but can't push, right? I do this, and then I know they're at C7, because C7 is responsible for extension. So I know that their injury is at the C7 level, okay? And there's only a few of those. It's going to be like drugs, right? You're going to learn a ton of them, right? You're going to learn a ton of drugs. You're going to use a handful of them, and you're going to get to know those ones really well, right? I know a ton of dermatomes, right? I know S1, or I know a ton of all of them, right? You could essentially say I memorized all of them at one point. I memorized all the functions of this, right? And I use a handful of them, right? I go S1 is in between the toes. Rectal tone is S2. I know T10, T4. I know kind of the basics of this. L3, L4 is flexion at the hips, and that's all I use, right? So out of all of them, that's all I use, because it gives me enough of a picture of where I can map out whatever I need, right? So I could memorize this and pretend to be really smart, right? But I didn't go into neurosurgery and I didn't go into neurology, okay? But I do remember the basic ones that I go to every time. So I've developed a kind of an ally of exam findings. And I go straight to my allies, right? Because they're going to tell me what I need to know when I need to know it. And I can generally get a gross picture of where a level of injury is at based on that combination of things that I consistently go to. So my theory is get to know them, get to know a couple, get to know them, use them reliably. And when they're there, you'll find them. When they're not, you're so familiar with them, you're like, well, the nerve's not acting right today, right? You know what I mean? So here's the dermatomes. So I don't remember every single one of these, right? I remember L4 comes across the knee. I remember S1 is actually, they don't show it here, but S1 is in between the big toe and the little toe. S2 is right around the anus. T4 is at the nipples. T10 is at the umbilicus. Those are the ones I remember. So I just have a couple in each spot, and then I can tell you based on where I find my deficit at, where I probably fall somewhere in there. Okay? And I just picked the ones that go along with a landmark, right? You could say, well, I want to know at the xiphoid process. That's what I'm going to remember. Fine, I don't care. Clavicles, that's what I want to know. Where the clavicles are at, that's C5. Fine, do whatever you want. I don't care, right? But get some that you're familiar with so that when you need to make an intelligent decision about something, you've got a reliable handful of neurologic findings that you can go to when you need them. Okay? So here is just a basic picture of the spinal anatomy. The core, you see, here's the dura mater, remember, the tough mother. It kind of protects this entire section all the way down. I've got my posterior longitudinal ligament here, right? I've got some other ligaments back here that we talked about. You can see where I create this foramen where my spinal nerve exits. If I have a bulging disc, it's going to push up against here, and it's going to compress that nerve, right? Here's my sympathetic chain ganglia, so I know this is a thoracic spine, right? So here's my little sympathetic chain ganglia that's hanging off the top there, right? Myotones, we talked a little bit about that just now, flexion, extension. I just remember a couple of them, right? Just enough to say flex, extend, hand grip, keep your fingers spread apart. I can rip through a motor exam of the hand in 10 seconds. But there's a ton of different ones, right? If you want to do supination, pronation, fine. Memorize supination, pronation. If you want to do flexion at the elbows, if you want to do extension here, if you want to lift here, if you want to do this, if you want to do this, if you want to, right? Just get a couple that you know are reliable and you can refer to when you need them. The ones I like to do are just what I showed you. Hand grip, pull in, push out, like you're riding a motorcycle, and spread out all your fingers, don't let me close them. And that hits all of them. And that's just what I do consistently, okay? Reflex pathways. This is a really nice thing to use when I have somebody who I can't get information from, right? I can't get information from you because you're not cooperative or you're comatose. Then I rely on deep tendon reflexes, which tell me whether or not you've got an intact spinal cord. Remember, a deep tendon reflex is a short arc that leaves the brain out. Gives me quick responses. So if I step on a nail, I get a quick reflex to lift my leg up, and then I say, oh, there's a nail there, right? As opposed to, damn, that hurts, you better pull your foot off that nail, right? Much slower. A spinal reflex arc is a very rapid, take cognition out of it, get a quick reflex, okay? And they tend to work in opposition of flexor extensor opposition and with opposite legs too. So like if obviously if I step on a nail, right, I don't want to jerk this leg up and not support this leg. So I'm automatically going to flex my quad on this side when I lift my leg on this side. I'm going to give myself some support, right? One of the ways to test this in people who you think are fabricating weakness, I forget what the sign is called, but when you say lift your leg up off the bed, lift it off the bed, lift it off the bed, lift it off the bed, and they say, no, I can't. I've got my hand underneath the opposite leg, and the reflex when you're trying to resist lifting is to push the opposite leg back, right? So I get extension, and I'm really testing the strength on the opposite leg and distracting them with the good leg, right? And then I switch it out and I say, okay, how about lift this leg, and they lift that one, but they also pull the one they said is bad back with good muscle strength, right? Just as strong as the other side. And then I can say, you're such a liar. No, I'm just kidding, I don't say that. But I bank it, right? They're like, okay, that's an inconsistent exam, and I'll document that as an inconsistent exam. So you can really take advantage of some of these reflex arcs, right? But if, let's say, you're out, you're comatose, then I'm going to start doing some deep tendon reflexes and checking those things. And I essentially am hitting tendons to give you that kind of quick jerk response back. So I can do it any place that I can really get to a tendon. And you got a biceps tendon right here, so I tend to just put a finger over the bicep tendon, have them really relax your arm, put a finger over the bicep, and you can feel it, you can like strum it like a little cord, right? So when I find that little spot, and I take my stethoscope or something and I just smack it, right? And I get flexion in the muscle, and the bicep as a response. Or if I tap the knee, or at the patella, I tap it and I get a kick out of it, right? Or I take their foot, and I just kind of support it, and I hit their Achilles, and their foot will plantar flex. Or you can bring their arm out to the side like this and have them relax it, and then hit their tricep tendon here, and they'll get a little kick, right? Or you find the little, kind of the tendon of the brachioradialis, you find it along here. It's a little harder to find, and you smack it, and their hand goes, and they kick their hand up, right? So that can tell me whether or not they're intact at that level. One of the things you have to do for people with spinal cord injuries is you check all the way down, and it's called an anal wink. And so you touch the anus, and it goes, and it winks at you. It's called, I'm not kidding, it's called an anal wink. But that tells me about C2. So much fun stuff to do in medicine. So you guys had no clue how exciting life was going to be, right? I don't know how to practice this one, but you touch it, and it goes dink, and it does this little response, right?
One of the things you delegate.
It depends very much on the patient. No, but that's an important part of right. You see in the trauma bay, we roll people and you do a rectal exam, right? I mean, it's one of the important things. One, I'm checking to make sure the prostate's palpable. They don't have a tear. They haven't torn their urethra, right? I ought to feel the prostate, because if I can't feel the prostate, I'm not going to put in a Foley catheter, because it's not going to go in the right spot if I have a torn urethra. So you feel and I'm feeling for rectal tone, and that gives me information about that spinal arc, right? You hit it and it squeezes down. So I'm checking rectal tone. So tone, or a wink where you just touch it and it goes like this, and it winks at you, that's an intact tone. It's obviously not something you're going to do in the field, but it's something you're going to see in the trauma bay. And you also have what's called a bulbocavernosus reflex, where if you, this is a little more awkward, but in a detail where you squeeze the glands of the penis, or you squeeze the clitoris, and you get a squeeze on the rectal tone. So, and it tells you whether or not you have an intact reflex arc. So it seems totally weird, right? Like, don't mind if I squeeze your clitoris and stick my finger in your rectum, but I have to check your reflexes, right? So typically what you do is you reserve that for someone who's got a Foley catheter. And then you just take the Foley catheter and you tug the Foley catheter, and it should squeeze down on your finger, right? The rectum should squeeze on it. But it's an intact reflex arc to those sacral spinal nerves. So there's a lot you can do on a comatose person in terms of knowing, hey, look, I know what I can expect, what's normal, what kind of things can I take out of a non-cooperative or uncooperative comatose patient to ensure that these things are intact, right? So those things can be as bizarre as they are. They can be very, very beneficial in terms of identifying people's injuries. So here's that arc, right? Painful stimulus that gives me some extensor stimulation plus flexor stimulation on the same side, right? So I kind of get that opposite. So I'm going to take advantage of that when I need to, when I'm doing a neuro exam on somebody. We talked about divisions of the autonomic nervous system: parasympathetic, feed and breed, rest and regeneration. I got peripheral nerve roots from the sacrum and the cranial nerve, so up top and down low, right? These ones go to the bladder, they go to the gonads, they go to the rectum. These ones tend to hit more of the pupillary and central functions here. Slow the heart rate, increase digestive activity, play a role in sexual stimulation. So, so actually the P, the way we remember this in med school is P is for point, S is for shoot, because ejaculation is actually a sympathetic function, and erection is a parasympathetic function. I think you guys probably think I'm like totally fixated on like sexual stuff, which I probably am, but there is some legitimacy when we're talking about neurologic function. Okay, so that's my justification. But this is why, again, why am I going to see if I take out, and I know, and the argument is, well, if I've taken out a spinal cord injury here and I have no tone down below, well, I'm not going to have parasympathetic tone either. But essentially what it is I still have some overriding parasympathetic function with no sympathetic intervention. So I've essentially, instead of providing a lot of stimulation, I've removed opposition. Remember how they all are in opposition? So I've removed sympathetic opposition, so I'm going to be kind of more, I'm going to be more relaxed, more vasodilated. So this is where that priapism becomes a very important neurologic finding, and it happens in proximity to the time of injury. Okay? So they didn't have it. This is one area where that 25% might be right. They didn't have it when you showed up, and then you bring them in and they have it. It happened in between the time you picked them up and the time you dropped them off. Okay? Sympathetic fight or flight, we talked about this, increased metabolic rate. It comes off of my thoracic and lumbar regions. It's going to decrease organ and digestive system activity. It's going to give me vasoconstriction. So if I fracture at T1, I'm going to be vasodilated below T1. And I'm going to be in spinal shock, right? Or with severe head injuries, I'll see neurogenic shock, where I've lost vasomotor tone, right? I've lost the ability to really clamp down. I've lost my sympathetic drive. So you'll get people who are very clearly demarcated sometimes where I have vasodilated exam and a constricted exam above, right? And I can tell that off the skin, right? I got warm, well-perfused skin down below and a hypotensive patient and clamped down, cool skin up above, right? It's because I've got sympathetic supply and attempt to compensate up high, and I've lost that down below, okay? So that's where we'll see spinal shock. What are the mechanisms of injuries for the spinal cord? Essentially, it's extremes of motion. So I get hyperextension, hyperflexion, excessive rotation, like we see with odontoid injuries, and lateral bending. I can have axial stress, which is diving injury, or axial loading in particular. I can have distraction, which is a hanging type injury. And then I can have direct trauma, blunt trauma, etc. So flexion injury here, I'm tearing fibers in the back and crushing bone in the front. The opposite of that is hyperextension injury, where I'm tearing ligaments in the front and crushing bone in the back. Flexion injury, rotation, distraction injury, you see this in hanging, penetrating injury. So lots of different mechanisms of injury, okay? Most of my injuries are going to occur where I have a transition from the various vertebrae. So cervical to thoracic, thoracic to lumbar, lumbar to sacrum. So I'm going to have more frequent injuries at these areas of transition, okay? Just because they're more susceptible to extremes in movement. There's a three-column theory to spinal cord stability. This is something that's more important for radiology and radiographs when you're assessing the spine, but it does tell you something structurally. I've got three columns. If any time I have two columns that are out, then I've got an unstable fracture, right? So if I fracture spinous process or transverse process alone, that's not an unstable fracture, right? But if I fracture my lamina and my pedicle and the posterior portion of my column, then that's unstable, right? If I get a crush injury of my vertebra or a burst fracture, that's unstable because it's two columns. So if I have fractures of two columns, then I'm considered unstable. Okay? Does that make sense? You're not going to know because you don't have an x-ray in the field, right? And truthfully, I'm not going to make that determination 9 times out of 10 unless it's glaringly obvious, right? But most of them I'm just going to treat like they're unstable until the neurosurgeon says, I don't look too unstable, right? Okay, set them up. I can concuss my cord just like I can concuss my spine, right? I can bruise my cord or my head. I can bruise my cord just like I can bruise my head. I can compress it just like I can compress my brain. I can have epidural hemorrhages. I can have epidural abscesses. I can have tumors that push up against my cord. I can have fracture fragments that push up against my cord. All of the same things that can damage your brain can damage your cord. I can cut it, lacerate it. I can lacerate it with bone. I can lacerate it with a knife. I can lacerate it with a bullet, right? All kinds of different things. Transection, devastating injuries. You can see right here we're at level what? Level 1, 2, 3, 4, 5, 6. So I'm at C6. So C4 and 5. So this is someone who should have intact diaphragmatic function, but nothing else, right? They're going to have little or no function of the, you might be able to shrug shoulders just a little bit, but they're not going to have any other functional activity, okay? Devastating injury. There's a couple of things called the cord syndromes, central cord syndromes, the incomplete cord injuries. This one, central cord syndrome, tends to be somebody who has a hyperflexion injury or hyperextension injury. It tends to be more what we see in motor vehicle accidents. what they'll do is they'll have motor weakness that affects the arms but not the legs. And the reason is because of what's injured here, I tend to have my leg function on the periphery and my arm function closer in, just where those spinal nerve tracts come together, right? So what'll happen is I'll spare this area out here and I'll have good leg function, but I'll have weak arm function. So I test people, so if I get somebody who's got a neck injury or a hyperextension or a car accident and they got weak hand grips, but they got good strength in their legs, I don't say that doesn't make any sense. That's bullshit, because you'd have to have both of them gone. You can't have your arms and your legs gone. I MRI them and I look for compression or injury or bruising to the central portion of the spine, because that's a common finding we see in trauma with hyperextension and hyperflexion, primarily hyperextension. Anterior cord syndrome, this is where we'll see that vascular supply that's impaired. When we talked about vascular supply with where it comes in and connects, and I actually have vascular supply that hits the front and the back separately. So if I take out my anterior vascular supply, then I end up with loss of motor function and sensation to light touch and temperature, but I retain motor, position, and vibration. So this is someone who will, and the reason is because motor, sensation, vibration tracks come back here, and all pain, temperature, and light touch all come along these tracks out here. So what I do is I get this mixed exam of, can you feel this? Yes. Can you feel that? No. Do you have strength? Yes, but I can't feel anything. Well, you're making it up, right? Be cautious that you're not blowing off somebody with a significant cord syndrome. Brown-Séquard, this is extremely rare, but it's typically a laceration where I involve one side, so penetrating trauma where I get one side of the cord that's injured. Some tracts cross down low and come up. Some of the spinal tracts come up and cross in the brainstem. So I might have, like in this circumstance, on the same side of my injury, loss of sensory and motor function, but then loss on the opposite side of my injury, pain and temperature sensation loss. So I get this mixed picture on one leg of motor and sensory, but then pain and temperature on the other. And you'd say, well, that doesn't make any sense, right? Anytime it doesn't make sense, treat it like it's an injury until we can get detailed imaging to prove otherwise, okay? Now, the most common one that you're going to see is going to be the central cord syndrome. We talked about a lot of this stuff. Spinal shock, we talked about. Neurogenic shocks, this is kind of a greater, more significant loss of sympathetic drive and function, but very similar in terms of, typically will be associated with cognitive dysfunction also. Bradycardia, hypotension. Here we talked about splitting cool, moist, pale skin above the injury where someone's clamped down, their sympathetic tone is there, opposed to warm, dry, and flushed below where they lost sympathetic tone and it's vasodilated out, right? See, it's not just me who, like, is totally fascinating. See, it's all over the place. Yeah, it's not just me. It's slides in the textbook. Yeah, here's some more on seam size up. We've talked about this. Mechanism of injury, always assume that they've got spinal cord injury. Learn how to do a good detailed exam, okay? And initially in your primary survey, give me 2 thumbs up. That tells me a lot, right? Well, I know they can do hand, right? So the reason I like a thumbs up is I know I'm going to get flexion, extension, which is this thing, right? Plus hand grip, right? So I get a lot, by just 2 thumbs up, I get quite a bit of brachial plexus, so I know that's good. And then wiggle your toes for me, move your feet, that tells me quite a bit, but that's really not enough, right? That's my initial survey, primary survey for major spinal cord injury that tells me, do I have anything in the cervical spine or below, right, that's going to be impaired. But then I need to go back, once I've got my initial survey done, and I should do a detailed, find a demarcation for sensory deficit, looking for some of the other signs that we talked about on a comatose patient, doing more detailed cranial nerve exam, and I just have my go-to 3 or 4, right? And it's testing for reflexes, a couple of reflexes that you can rely on. things like that are going to be very, very important in terms of how well, in terms of how well you've identified injuries. But I would treat people like they have spinal cord injuries until proven otherwise if the mechanism was there. Now, penetrating trauma versus blunt trauma. If you don't have a neural deficit, I don't backboard the spine. I don't, right? Because if it's there, the damage is done. Okay, I'm not going to make it worse. I'm not going to make it better. Your damage is done. Damage is done. Penetrating trauma, I don't really care. Okay, blunt trauma, I care because a lot of those can be corrected and are amenable to fix.
You mentioned one where it was the opposite side to that, but when you're doing all those, if it's not equal on both sides, is that more brain, not
that would be,
spinal cord?
it could be potentially more brain injury, or it could be damage to the peripheral nerve. So it could have a brachial plexus injury, right? So let's say I got someone who got shot right here. That's not brain injury, but I'm still going to check that stuff for nerve dysfunction, right? So if they can't give me hand grip or flexion, or let's say I got a deep laceration to my antecubital fossa, right? Well, I need to know, do I have, clearly it's not going to be brain because the guy just got cut, but I know how to identify injury of those various nerves, right? And even if you can't remember, I can't remember if it's the median or the ulnar or the radial, all you need to say is, it got weak hand grip, or weak extension of the wrist, or weak extension of the hands. No sensation on the pinky, no sensation on the thumb, right? Just say those sorts of things, but at least you know you're hitting the major stuff and you've identified a potential neurologic injury. Okay, make sense? Remember, we can't clear people who are intoxicated. I can't clear people who are not able to cooperate in an exam. Altered people, I don't clear their spine. Intoxicated people, I don't clear their spine. Injuries above the shoulders, I'm very skeptical and I'm very hesitant to clear anybody's spine, even in the absence of pain, particularly in the elderly. Distracting injuries can be anything from a femur fracture to a splinter, right? I mean, truthfully, you get some people who are very animated. But generally what I'll do is I'll be like pressing on their back. They'll say, no, it's not my back, it's my shoulder. No, it's not my back, it's my shoulder. It's not, it hurts in my leg. They're distracted. Clearly they're distracted. And sometimes I'll just ask them, are you able to focus on your neck, or do you have other injuries that are keeping you from, I'm going to examine your neck. It's very important you can focus on your neck. Is your pain so bad in your leg that you can't focus on your neck? No, yes. And then I'll just ask them, do you feel like you're distracted? Okay, makes sense? I think it's better to do this after I have somebody out of the acute phase of their injury, right? Because the adrenaline surge that goes with an injury, right? But if they've been down for a while and they're like, oh God, my leg is killing me, right? Then they're probably someone who's ready to be examined. Otherwise, if the mechanism's there, I would just do it. Again, ABCs. This is where video laryngoscope is really nice if I need to keep my cervical spine immobilized, right? If it's full of blood, it doesn't do me a damn bit of good because all I'm going to see is blood, right? Because that's all the TV screen sees, right? But if I have cervical spine precautions and I don't want to really stick somebody's neck out, then that's when the video laryngoscopes are really handy. Rapid trauma assessment, we talked about that. Babinski is going to an infantile reflex that's lost by about 1 year of age, about the same time that kids start walking. They're fully myelinated, and they will end up with a normal flexion. So when you strike the bottom of their toe, or the bottom of their foot, their toes go in. But in abnormal response, their toes will go out. Another thing you can do to find upper motor neuron testing is you take the ankle and the top of the foot, kind of up by the toes, and just kind of wiggle it a little bit, and then push real hard and and dorsiflex it. So get a little wiggle and then forcefully dorsiflex. And most people, you'll get one quick jerk out of them, right? Eliciting a reflex response. But what will happen is the people with a significant injury, upper motor neuron injury, they'll kick back and they'll keep kicking. It's called sustained clonus. So with some people, when they can't cooperate with an exam, pull the ankle, take the foot, and then wiggle a little bit, and then give it a forceful dorsiflexion. And then if they kick back like this and they keep doing it, that's called sustained clonus. and that's a sign of significant upper motor neuron injury, so spinal cord and higher. I'm not going to get into that. You guys all know how to do this kind of stuff. We're going to do this stuff in the lab. We're going to go over it. You're going to have to do it the way they want you to do it for the National Registry, and then you're going to relearn what we want you to do for local protocol. So, C-collar, make sure it fits. You can't tell me any time I see a C-collar with a gap like this big coming off the shoulder. Remember, it has to. It's designed to support people. It's got to be put on the right way. Make sure that it fits well. Your indicator is from the angle of the jaw to the top of the shoulder. So if I've got, how many do I have? Like 3 fingers, maybe 4 fingers. Then that's the gap that I should have on my collar when I size it. So make sure you're sizing it appropriately. Standing takedowns are total horseshit. I don't think you should use, but whatever. Learn it for the registry. Right? If I've got somebody who's walking and I'm worried about spinal cord injury, it's been well documented that you assist them to get, and then you can assist them into a supine position. A standing takedown is total horseshit. But learn it for the National Registry. Helmet removal, when to do it. 2 rescuers, have a plan. Don't try and do it by yourself. Lateral pushing when trying to immobilize people is really bad, right? Because it's, think of it like a bow. If I push them like this, I'm going to arch it. So what I want to do is anytime I want to move somebody laterally, I'm going to go up, down. I'm going to kind of do like, what do they call that when you're sailing? When you go tacking. You're kind of like tacking, right? You're going, so you up, down, seesaws. I think that's what Charlie said, the same thing, right? And that's how I'm going to get somebody from this person, or from this position to this position, instead of just pushing them over. And go up, down, okay? Or up, down, up, or whatever it takes to get them there, okay? Dopamine, this is something that you may be using here for spinal shock, right? Remember, I want to restore sympathetic tone. Remember we talked about dopamine, how it's kind of a dose response or a dose specific drug. So at low doses, I'll get dopaminergic receptors. At medium-sized doses, I'm going to get beta receptors. At high doses, like 10 to 20 mics per kilo, I'm going to get alpha receptors. Okay. So the more dopamine I use, the more it's more selective at lower concentrations. It's less selective at high concentrations. Something that we need to know about dopamine. So in low doses, I'm going to hit these kind of mild dopaminergic receptors, which we'll never use, right? Just don't go 2 to 5 to waste your time. Go straight to 5 and up. So we're going to stay between 5 and 10 for the beta effect. 10 to 20 for the alpha effect. So if I got someone in neurogenic shock, where do I want to be in? I want to be in the higher levels of my dopamine, right? I want to be up high into the 10 to 20 range, okay? Atropine for bradycardia. Anybody who's in neurogenic shock, they're going to be bradycardic hypotensive. This is someone I might want to use atropine on, right, to take advantage. If it's a vagal nerve that's driving it, then I want to counteract that vagal nerve, right? This is my anticholinergic of choice, so I'm going to use this to combat my vagal nerve and reverse bradycardia, okay? Sedate people. All right. I have half an hour to do soft tissue. Soft tissue is like the most boring trauma there is, though, okay? So we'll rip through it. Take a quick break and we'll come back.